At the outset, I would like to thank Bhalla sir for giving me the opportunity, and of course the AIS Scientific Committee for giving such a nice time for this talk. Uh, Dr. Bhalla sir has already talked about biometry, perfecting. See, we are lucky. Our generation is such that we have access to a lot of gadgets and we can try and perfect our surgery. There are no financial interests. We all know that there is a lot of cataract burden for all of us to treat, and there are very high expectations amongst uh, patients because they are aware of various technologies, and as a surgeon it's our aim to give the perfect results. So basically there are two aspects. One has to be perfect in the technique what we perform, and second is we have to do all this technique consistently and give reproducible results in even in challenging situations. And I am sure the speakers after me are going to talk about challenging situations like PCR and other aspects of it. Before we think of perfecting the technique or giving the perfect results, the most important step which we must follow everybody is that preoperative evaluation. Whenever we have a huge list, especially we tend to skip doing examination of the patient ourselves. So it's always better to check the patients before operating on slit lamp, thorough slit lamp examination, AC depth, watch for corneal opacities, dense arcus. Most important is if you are planning for premium IOLs, evaluation of ocular surface and ruling out dry eye is a must. And you have to rule out zonular instability. There are many times surprises on the table. We miss zonular instability in preoperative examination, and on table we are fixed because then we find that there is a lot of zonular instability. If you are planning toric IOLs or toric multifocals, topography is a must. And I feel ideally for all the cases we have to do detailed retinal examination prior, and OCT should be done in all the cases if it is possible. Biometry, Dr. Bhalla sir has already talked about, and there are certain intraoperative tips which we must understand. You have to avoid blunt keratome, that is a standard, proper staining, avoid tight wound, and Harshinov technique is the best thing. In modern cataract surgery, I think the most important step in phacoemulsification is capsulorhexis, and integrity of the capsulorhexis edge gives the strength to the capsule to withstand all the fluctuations in intraocular pressures during fragmentation of the nuclear fragments. So to understand capsulorhexis, there are basically different forces which act on the capsule during capsulorhexis. These are 4 different forces. The extrinsic force which is applied by the surgeon during capsulorhexis. There is always a centrifugal pulling force by the zonules. There is always leakage of OVD from the wound, from the anti-aqueous, which again leads to extension of capsulorhexis at the periphery. And another important aspect is the posterior thrust from the vitreous. So if we know all these forces, then it's quite easy to perform capsulorhexis consistently. Capsulorhexis has to be of adequate size. Whatever technique you are using, it should be of adequate size. If you are performing a manual small incision cataract surgery, I won't call it as a not good surgery. It's good in certain particular patients where there is a dense grade 5, grade 6 black cataract. You can always do manual small incision cataract surgery. In that, since the nucleus is of bigger size, you should aim for a bigger capsulorhexis in such case. While performing capsulorhexis, always maintain the depth properly. If there is leakage and if you find that anterior chamber is collapsing, then it is always better to refill the anterior chamber with viscoelastic devices, so that you have to maintain the anterior surface of the cornea, anterior surface of the capsule flat. In intumescent cataract, it's better to aspirate the interlenticular fluid prior to the capsulorhexis, and there are various forces, basically shearing and tearing technique, which you have to apply properly to complete the capsulorhexis. So ideal capsulorhexis, we all are aware, should be of 5.5 to 6 millimeters, and it should be properly centered on the visual axis. The next important step in phacoemulsification, because phacoemulsification is a gold standard in modern cataract surgery, is management of nucleus. And in management of nucleus, you have to protect endothelium properly. If you want good results on the day 1 postoperatively, endothelium has to be protected. For that, you have to select proper viscoelastic device depending on the grade of the cataract, and Arshinov's soft shell technique, all we know, is the best way to protect the corneal endothelium. There are various techniques you can do: 4-quadrant, stop and chop, direct chop, whatever works best in your hands in most of the cases or in all the cases you can follow. I feel stop and chop is the best technique to treat all grades of cataract, and basically it is stress free for the surgeon. If you try other techniques like direct chop and all, there is some amount of stress amongst the operating surgeons. As far as the machines are used, I still feel no financial interest. The torsional phaco, Ozil technology is the best to cut all grades of cataract properly. So this is a short video which shows that it's a quite dense cataract, and we are trying to remove it uh, by a stop and chop technique. A proper trench has to be created. Once you create the trench, you can just crack the nucleus. Time up, or I have some time?
Have a minute more, sir.
Okay, fine. And then even such a dense cataract can be easily removed with stop and chop technique and proper use. So to summarize, if you want to give all the perfect result in all the cases, it's always better to do proper pre-operative assessment. You have to plan the surgery depending on the grade of the cataract, type of the cataract. Avoid repeated entry into the anterior chamber, avoid tight wounds to avoid wound burns, avoid excessive phaco power, proper selection of viscoelastic in the back phaco. And there is a concept of 1 minute phaco. At the end of 1 minute, you can just refill anterior chamber with viscoelastic device so as to protect the endothelium, and see to it that the viscoelastic device is retained in the anterior chamber throughout the surgery. Another important thing is, as a surgeon, you should not have ego that you will do all cases phaco in 1 minute. Speed is not I have finished case in 2 minutes or something like that. The recovery time for the patient has to be fast and not the surgical time. So kill your ego, safety first, and then I am sure that you will achieve good results in all the cases. Thank you, Dr. Bhalla sir, again for giving the opportunity. Thank you.